Good morning and thank you for listening. My name is Eleanor Robinson and I'm a third year podiatry student. Today I will be presenting a case study on the surgical approach to a symptomatic forefoot within a podiatric setting. Let's begin by briefly looking at the history of a Morton's neuroma. It was first described in 1835 by Savini as a fusiform swelling of the common digital nerve at the third web space. Then in 1845, the Queen Victoria's chiropodist Gerlach published a discussion on the management of the condition. However, its modern name came from the American orthopedic surgeon Thomas Morton, when in 1876 he published a case series of 15 patients with the condition. However, the term neuroma to describe it is often cited as a misnomer, as a true neuroma is defined as a tumour or mass growing from nerve tissue and usually consists of nerve fibres. Histological studies have shown that excised neuromas show proliferative fibrotic perineural tissue, indicating inflammation of nerve tissue rather than growth. Morton's neuroma can be more accurately described as an entrapment neuropathy due to compressive stresses of the deep transverse ligament upon the plantar digital nerve. To obtain clinical diagnosis of a Morton's neuroma, a thorough forefoot assessment must be performed. There is no pathognomonic clinical assessment that will definitively conclude the presence of a neuroma, so a combination of both subjective and objective history is vital. Objective assessment should include a Mulder's click, lateral foot squeeze, plantar and dorsal palpation of the metatarsal heads, and using light touch and sharp blunt neurological assessment to see if there are any abnormalities outside of peripheral neuropathy. These objective assessments can be combined with imaging, plain films to rule out any osseous involvement, and ultrasound to establish differentials such as bursitis, capsulitis, or plantar plate tears. However, these can exist asymptomatically in patients, so it is advised to not rely solely on imaging during the clinical diagnosis. A 45-year-old female has presented to the clinic with a symptomatic forefoot seeking a surgical opinion. It has been previously diagnosed as a third web space Morton's neuroma and is unresponsive to previous conservative therapy. Her medical history includes obesity and non-insulin dependent diet-controlled type 2 diabetes mellitus. Serology report shows she has elevated C-reactive protein levels at 25 milligrams a litre. Obesity and diabetes mellitus are both linked to increased incidences of foot pain and deformity. Increased fat mass has been associated with biomechanical changes and increased plantar pressures. An increase in visceral adipose tissue provides a highly active endocrine system for the production of low-grade inflammatory markers. Visceral adipose tissue produces inflammatory mediators such as CRP, fibrinogen, interleukin-6, and low albumin concentrations. These acute phase reactants are typically elevated in healthy obese patients. CRP is a particularly sensitive inflammatory marker, so chronic disease can often be enough to elevate levels even though there is no sign of infection. Prolonged foot pain can also be associated with poorer mental health outcomes. The causal correlational relationship is not explicitly known, however, the two factors are closely linked and commonly present together clinically. Conservative treatment taken so far will have been extensive so as to delay the need for more invasive procedures. This has included manipulation and mobilization, wider footwear, metatarsal padding, shockwave therapy, orthotic therapy, and valgus or varus wedges placed inside of footwear. However, conservative therapy often does not resolve the cause of the pathology, and symptomatic relief may only be temporary. There are several surgical options available to us, and we'll be looking at these 6. We'll be discussing both plantar and dorsal excisions, dorsal decompression, radiofrequency ablation, corticosteroid injection, Botox injection, and alcohol sclerosing injection. We will discuss these options in order from most invasive to least invasive. Morton's neuroma, is the only compressive neuropathy that is commonly treated by surgical excision. Plantar excisions are some of the earliest performed procedures for the condition and are still frequently used today, although they are slowly reducing in popularity. The excision is performed under general anesthetic as well as a regional ankle neuromuscular block and tourniquet. For a single level neuroma, such as in our patient, a vertical incision is made over the metatarsal heads. For multiple neuromas, a horizontal incision is made. The plantar digital nerve is resected as far back proximally until the nerve tissue is embedded into muscle tissue. Ideally, this is described as 1 to 3 centimeters proximal to the nerve bifurcation. The deep transverse ligament can be resected to provide further decompression at the web space. However, it is not always performed, although it does depend on the surgeon. Improved pain scores are noted in 96% of patients who have a deep transverse ligament resection. However, complications of keratosis and painful scar tissue and wound dehiscence have made this option more unpopular to patients in comparison to other techniques. A dorsal approach is becoming favoured for surgical excisions of Morton's neuromas. The technique holds many advantages over a plantar incision, including the prevention of painful scar formation or keratosis, and the ability for the patient to weight bear immediately following the procedure, in comparison to the prolonged 6 weeks of non-weight bearing needed for a plantar incision. For the dorsal approach, it is carried out under the same conditions as a plantar approach. However, a longitudinal incision is made to the dorsal aspect of the affected interdigital web space. The deep transverse ligament is then resected so that the plantar digital nerve can be more easily accessed. As with the plantar approach, the nerve must be resected 1 to 3 centimeters proximal to the bifurcation. This helps to prevent amputation neuroma occurring, but can be more difficult to achieve completely in the dorsal approach than the plantar approach. 85% of patients report excellent and good results after a dorsal procedure. One article did discuss the idea of a less invasive approach to a surgical incision. In an effort to reduce the formation of amputation neuromas, it is suggested that the release of the deep transverse ligament and simultaneous suspension of the neuroma over the dorsal transverse ligament can produce good post-operative results. The procedure is performed under a femorosciatic nerve block. A 3 centimeter straight dorsal incision is then performed over the affected joint space. The dorsal transverse ligament is dissected to the extensor hood of the adjacent metatarsal head. The deep transverse ligament is then dissected before neurolysis of the neuroma occurs. The neuroma is then transpositioned dorsally to be suspended over the dorsal transverse ligament, which is reattached with sutures. Adhesion barriers and a silicone drain are inserted to prevent hematoma. Following the procedure, the patient can partially weight bear using heel and lateral pressure for 2 weeks. Instead of massage and passive flexion exercises of the digits are encouraged. At a 24-month follow-up period, 95% of patients reported either a good or excellent result as according to the Coghlan scale. Radiofrequency ablation is the heat necrosis of affected nerve tissue, typically performed under ultrasound guidance. This can be performed in an outpatient clinic setting. A sterile probe with a 10 mm active diameter is inserted at the dorsal aspect of the affected web space. The myelin sheath is then necrosed using 5 2-minute cycles at a temperature of 81 to 90 degrees Celsius. The mean VAS reduction for patients was recorded as 7.4 to 2.2 at a 6-month follow-up. However, there can be a high long-term failure rate associated with this procedure due to recurrence, so ensure that the patient is aware of this and the discussion of resorting to surgery may still occur. Sclerosing injections use an ultrasound-guided dorsal approach. The process injects an alcohol solution containing 0.3 milliliters of ethyl alcohol and 0.3 mils of local anaesthetic for a total volume of 0.6 to 1.0 mils, depending on the size of the neuroma. The procedure reports a medium-term success rate of 71%, with a vast reduction from 8.0 to 4.0. As with radiofrequency ablation, there is a higher long-term failure rate, so there must be a discussion around the idea of progressing to surgery. Corticosteroid injections are often the first line in invasive treatment options, typically performed under ultrasound guidance to allow for a more targeted approach and improved long-term pain outcomes. A dorsal injection is performed with a 23-gauge needle using 40 milligrams or 1 ml of triamcinolone and 2 ml of 1% lignocaine solution. A VAS reduction of 6.7 to 3.0 is noted and can improve symptoms for up to 6 months. Patients can treat any residual discomfort using NSAIDs and ice, but are able to immobilize immediately after the procedure. And there was a pilot study that investigated the use of Botox in treating neuromas. Botox has been used successfully in treating other neuropathic pain types such as carpal tunnel syndrome, trigeminal neuralgia, and diabetic polyneuropathy. 50 units of onabotulinum toxin A in 0.5 mils of sterile saline was injected directly into the neuroma. The study reported vast improvements from 7.0 to 3.74 at a 3-month follow-up. However, there is no long-term follow-up and no complications reported, which highlights the need for further studies in the use of Botox for Morton's neuroma. With all procedures described above, there are risks and complications to consider. For a surgical excision, scarring, bursitis, infection, and dehiscence are the most common complications. However, digital deformities, epidermoid inclusion cysts, and reduced plantar cutaneous sensation can all occur too. Injections have been reported to have significant injection pain, despite the inclusion of an anesthetic, bruising, paresthesia, and recurrence rates as well. So with these complications in mind, it is important to choose the correct procedure for the patient. A history of diabetes and obesity does complicate it due to increased morbidity risks of undergoing a general anesthetic and increased post-operative complications. As a result, the preferred initial invasive procedure would be to perform a radiofrequency ablation of the nerve. It is minimally invasive with good reported results. The patient can weight bear immediately, with there being no incision wound to increase risk of infection. Ablation was also chosen over a corticosteroid injection due to its higher long-term success rate and the patient having a history of being non-responsive to more conservative therapy. Multidisciplinary involvement would typically involve the GP for referrals, imaging, and histological examination if a patient does undergo an excision, as well as referrals to a dietitian and exercise physiologist, where research has stated that they can assist and improve glycemic control and weight loss measures for patients. The peri, and post-operative considerations are more targeted towards general anesthetic procedures. However, it is important to be aware of these considerations when deciding which procedure is best suited to a patient's needs. Obesity and diabetes are both complicating factors for surgery. For preoperative considerations, it is highly recommended that patients seek screening for sleep-disordered breathing and closely monitor blood glucose levels and supplement with a short-acting insulin when fasting preoperatively. If a patient's metabolic state becomes unstable, the surgery should be cancelled or delayed until the patient is stable and it is safe to proceed. Perioperative management of the obese patient typically includes the ramping or sitting of the patient in the theatre to reduce pressure on the esophagus and reduce the failure rate of intubation in the patient. It is recommended that a venous thromboembolism prophylaxis is administered, as obesity is considered a risk factor for VTEs in a surgical setting. Minor surgical procedures under an hour can be passively monitored for hyper or hypoglycemia, with the preoperative maintenance dose of insulin usually being enough. Again, post-operatively, glycemic control should be a priority for the patient with pain relief as needed. It is best to avoid long-acting opioids due to the increased risk for sleep apnea in obese patients. The patient following a radiofrequency ablation is advised to rest for 24 hours following the procedure, with weight bearing and mobilization encouraged the following day, and ideally a review in 7 days. Further communication with the patient should discuss the idea of progressing to surgery in the future if there is recurrence. It should also include discussing the link between obesity, diabetes, and foot pain, and how seeing a dietitian and exercise physiologist may benefit the patient for weight loss and glycemic control if they are unable to look at pharmacologic therapy. Following the radiofrequency ablation procedure, the patient is able to weight bear immediately, and although advised to avoid strenuous exercise for 24 hours. Some mild tenderness at the injection site should be expected and is normal. The patient is able to use ice and NSAIDs to relieve the pain as needed. It is recommended to review in 7 days for any post-op complications. And thank you for listening to my presentation.